last session on fetal echo. We had the previous 4 sessions. Today we are going to talk about structural lesions. I think it is a vast topic, and so we will be probably focusing on only few things today. What is important for all of you is to understand when to diagnose, how to diagnose. And second thing is, once you know this lesion is suspected, what do we do next? So these are the few things which I would be highlighting. Let's see how many lesions we can take in the next maybe 40-45 minutes. Now, I want all of you to be interacting in the chat box because the lesions are very similar. All of you are comfortable understanding the concept of the lesion and how to pick it up postnatally. So it's going to be very similar. So it'll be nice if all of you could write your answers with every lesion when we started. So let's see here. This is a 26-year-old, gravida 2, para 1, and 21 weeks of gestation. She gets referred to with suspected LV dilatation in the usual anomaly scan. So let's see what is there here. I hope it's playing for all of you. Can you see the video playing? This is a 4-chamber view, an axial cut. Anybody thinks anything is wrong in the 4-chamber? Yeah, you feel ventricles are dilated. Any specific ventricle do you think is dilated? Some effusion is present. Yes. So if you just keep focusing, I haven't shown you the situs, etc., but you can see here, this is aorta, which is pulsatile. This is very much going to be the left side of the baby. And this is the IVC entering the right atrium. These are the pulmonary veins entering the left atrium. This AV valve is much closer to the apex. So I will put this as RV and this is LV. And then when I sweep anteriorly, I can see the left ventricular outflow tract and right ventricular outflow tract. Here, this is the RVOT, that is the LVOT, branch PAs are bifurcating and I have a left arch. So grossly, I feel the structure is normal. Now, which part? Yes. So what I feel is that the right ventricle looks okay, but the left ventricle, especially when I'm sweeping, see this is posterior sweep. I'm freezing here. So you can see here the posterior sweep, the LV looks dilated. Do you also feel that the myocardium looks a little different? See, it doesn't look like a normal myocardium, this one. So what is it? Could it be an abnormal LV myocardial disease? See this? This is not a normal myocardium. When I start, this is normal LV. But when I'm sweeping posteriorly, there is something which is coming out of LV cavity, giving an impression of LV dilatation. So it is an outpouching from the posterior aspect of the left ventricle. So it could be LV aneurysm. So this is sort of a tentative diagnosis. Now, whenever I have this diagnosis, the effusion looks acceptable to me, but yes, there is trace pericardial effusion, which is evident. Now, what do I do now is the next question. So what questions will arise? These are the questions which are very common for every single cardiac lesion when you see. So the next question comes, do I know the cause for it? And is there a treatment now? Are there any associated morbidities which I need to rule it out during pregnancy? Do I need to follow this lesion in pregnancy and what will I keep seeing? Do I need to change the place of delivery or mode and timing of delivery? And what steps need to be taken immediately after delivery? And the most important is the prognosis. The mother is 21 weeks of gestation. Obviously, they're going to ask you a lot about the child and a decision about query termination. So all these questions will come in front of you the time when you pick up a structural lesion. So for this particular child where we think that this is left ventricular aneurysm, we know that this is usually idiopathic. It's usually idiopathic. It's something to do with the endomyocardial dysplastic etiology. And most of the times it does not have a reason, but sometimes you could pick up an intrauterine infection, etc., etc. But I would say I have never seen a cause found for a LV aneurysm. So now that I don't know why is it like formed, then what do I do? I need to understand that LV aneurysm can cause arrhythmias, including life-threatening ventricular tachycardias, and it can also cause a thrombus formation, thromboembolism, sometimes rupture and sudden death. So this counseling is important. Do I really monitor them during pregnancy? Yes. These outpouchings can grow over time, and it is said that if it's an elliptical LV geometry, then it has a little negative impact and poor prognosis. So this information I have, with this understanding, what do? I will monitor them likely once in 2 to 4 weeks for rhythm, any development of VPCs, any arrhythmias, development of mitral regurgitation, any evidence of cardiac failure because my systolic function could be impacted or emptying of the left ventricle could be an issue. I need to deliver at a tertiary center, though immediately after birth, I'm not going to do anything active except monitoring in the ICU for rhythm, LV function, and then follow up on regular basis. Surgical role is going to be sort of controversial based on the complications and based on the size of the ventricular aneurysm. The role of surgery would come, but remember it's controversial, and the long-term prognosis would also be very difficult to predict. But in terms of percentages, a very little percentage of children may misbehave. So this is sort of a counseling you're giving to the parents. So with this understanding, remember what's the role of pediatric cardiologist. Whenever we pick up a structural lesion, there is one thing which we think about is counseling, and second is there any need for perinatal interventions? And these interventions are considered in the antenatal period, natal period, and postnatal. Now, antenatal means what? The question and discussion about is termination an option? Any intervention in utero, including, for example, if you pick up an arrhythmia, rule out associated anomalies when I know that, for example, I pick up a truncus, then my counseling should be towards discharge and monitoring during pregnancy, whether I need to monitor weekly, 2 weekly, 4 weekly, what do I need to see? AV valve regurgitation, ventricular function, any arrhythmias, etc. During pregnancy, do I need to change the place of delivery, time of delivery, and mode of delivery? So the place of delivery, we all understand, all ductal dependent lesions, arrhythmias, etc. Ventricular dysfunction should be delivered in a center where you have cardiac treatment possible. The timing of delivery could be modified in cases, for example, I have AV valve regurgitation and precardiac failure. I might want the child to deliver early. I have absence of ductus venosus and evidence of heart failure, then I might want to deliver early. If there is arrhythmias and the child is closer to 35 weeks, then I might consider delivering rather than considering maternal treatment. Mode of delivery, most of the times it does not change, except, for example, I have complete heart block and monitoring for fetal distress becomes difficult, then only I would consider. You would actually prefer a normal delivery for lesions which are more complex and would be expected to have palliative treatment. And postnatally, in terms of early intervention, what all will I do at birth? So this sort of a chart should come in our mind as soon as we diagnose a structural lesion. And all these things is going to be based on your understanding about the cardiac condition, which you have it based on your postnatal knowledge. And though this graph is a little old, I actually like this graph because you can see here, the parents are going to ask you what happens if I operate. The first step is explaining them the surgery, but then the long-term prognosis is very important for congenital heart disease. And here you can see that this is a general population, the topmost line, and that is the sort of the future of a child at 40-50 years of age. And if I see the ASDs, they are closer to normal. And if I see the PDAs, they are closer to normal, and the coarctation most of the times in the first 3 decades are closer to normal. And so this is what it starts with. If you see the VSDs, if you see the tetralogies, if you see the TGAs, and if you see the univentricle. So even tetralogies, you would see this, that after the second, third decade, arrhythmias, reintervention, and sudden death. So based on this, your counseling should go. In general, I would say that you would put tetralogy in between the VSD, ASD coarcts closer to normal and the univentricular truncus, etc., much away from normal in terms of long-term outcome. So now with this, I think this is just that a complete scan is important, which is the extended basic scan. You start with your axial view, 4-chamber view, and we have learned in the previous LVOT, RVOT, 3-vessel tracheal. So a complete evaluation is necessary. Do not skip any steps, including situs. Because subtle information related to situs, for example, if I have IVC interruption, I know this baby can turn towards left-sided isomerism. So these are very subtle clues. Also, before I try understanding the structural problem, I need to figure out what is left and right for my baby. Otherwise, it will be very confusing as you go towards sequential segmental analysis. So we know that this is the cut for situs, 4-chamber. I go a little interior, I get outflow tracts, and 3-vessel tracheal. I go to sagittal, I have the bicaval and the aortic arches. Now let's see the first case. So all of you can answer in the chat box. I will be playing the video for you and try to see what you think about this. This is 26 weeks, primigravida. Can you all see the video? Do you want to go to the 2D image once again? Kavita, is it playing for all of you? Okay. Any thoughts from your side? Funny atresia, that's very good. So yes, so as we start here, this is a 4-chambered heart where you have a VSD. This is the single great vessel which is arising, and I have the smallish vessel in the place of pulmonary artery. As I go to the 3-vessel view, this is a single vessel which is coming, and then I have a smallish vessel anteriorly, this one. So if you see on color, you can see here the VSD, and then this is the large vessel which is overriding the interventricular septum, and then you have this vessel which is hardly filling. The vessel which is coming from the overriding IBS is filling up beautifully in terms of forward flow. So basically, what do I see that? I have a VSD, I have 2 vessels. In the place of 3-vessel view, I have 2 vessels, and here you can see something. This is a right arch. So this one You can see here, this is the trachea. This is the trachea. This is the right arch. This is the left ductal arch. So the aortic arch is actually going to the right and making a U here. This is what makes it a right arch. So I have a single great vessel. This is the aortic arch. This is the ductal arch. So this is a right aortic arch, VSD, pulmonary atresia. Yes. So even in three vessel view, only one outflow tract is seen. Yes. So VSD pulmonary atresia, I know one very important thing is 26% will have extra cardiac anomalies and or chromosomal abnormalities. So I have a lot of implication. Make sure that the other organs are okay. My genetic evaluation is done. Genetic consult is done. Now the second thing is, see if you can see the central PAs. Actually, in this baby, you can see the central PAs. When you go to the three vessel view, you can see just before that, these are the branch PAs. This one and this one. So this baby does have a confluence. When I have a confluence, it makes me feel that I'm probably going to fall into this category, where I have central PAs which are supplied by a PDA, unlikely to be collaterals. So the basic difference, all of us know that if it's central PAs by PDA, my baby is going to be very sick at birth, unlike collaterals. Collateral babies usually are okay at birth, but as time will go, the surgical interventions become more difficult. So if it's central PAs by PDA, very likely I will need a systemic to pulmonary shunt, and then later on a total correction, a lot of implications because of the RVOT, which is reconstructed by multiple ways, needing re-intervention in the future. If I have collaterals, I'll be thinking in terms of unifocalization. It could be a single stage, it could be staged, and the prognosis long term is going to be a little inferior compared to when I have central PAs. So this is sort of what counseling will go. And generally, I would say the 5-year survival rate is approximately 90%. The freedom from reoperation is only 70%. So chances of repeat surgeries are very high. Now, whenever I say pulmonary atresia, I can also have intact ventricular septum. So with that situation, I need to understand that when I have intact ventricular septum, the disease is predominantly proximal to the pulmonary valve. If I have pulmonary atresia VSD, then the disease is predominantly distal to the pulmonary valve. So that's the basic difference. And here, if it's intact ventricular septum, I will also have to look into my RV size, tricuspid valve size, and my long-term future could be biventricular, univentricular, or a 1.5 pump repair. So I think I will not go into the detail of this. And here also you have a very similar long-term future in case I have a biventricular repair. But for a univentricular, I would say it's not going to be as equal as a biventricular repair. So whenever I see a pulmonary atresia in fetal life, these are the thoughts I should have. First, let me check if there's a VSD or not, because that's going to make a difference. If it's intact IVS, then I will go into the understanding of tricuspid valve size, Z-scores, RV length, Z-scores, and presence of tricuspid regurgitation. Let me see if I can see a confluence and the size of the pulmonary arteries. The sidedness of the arch could help you guiding a little bit towards non-cardiac issues, and presence of thymus, again related to non-cardiac issues. And that will probably decide your long-term prognosis. Definitely, we need a prostaglandin standby, and might need an neonatal PT shunt. Redo interventions counseling is extremely important. There are times where no intervention is considered if the pulmonary artery confluence is not there, collaterals are not sizable, stenosed, not in a position where unifocalization is feasible. So that little possibility needs to go to the parents that sometimes even intervention is not feasible. So I think this was related to pulmonary atresia and ventricular septal defect. Remember that the studies which have picked up this lesion in fetal life and compared it to lesions when they are picked up postnatally, somehow for the right heart, it probably has not made much difference in terms of long-term outcome. However, the rate of termination has been found to be much higher when such a lesion has been picked up in fetal life. Okay, now let's see this. What is this? All of you can answer in the chat box. Okay, any thoughts? Tricuspid atresia. Okay, I understand that confusion. Now let's go step by step. Let's go step by step. This, okay, this is thick wall. This is aorta. This is IVC. Okay. You also can see the stomach bubble as you go. This is the stomach bubble. This is the apex of the heart descending out the stomach bubble. So I know this is left, this is right. Now with this understanding, let me go. You can see here this pulmonary veins to roof of left-sided atrium, interatrial septum. This is dilated right atrium. So yes, there's a little confusion about AV valve also. Let's see. So I know that, see, this is a single valve. This valve, I'm actually not showing it much. This chamber is so small and this is dilated. And then when I see it going anterior, you will see that the vessel which is coming from this side, which is the left ventricle, is small. And then I have the pulmonary artery, which is bifurcating into a left-sided aortic arch. Just have a look once again. This is the confluence. This is the dilated ductal arch. So LV is hypoplastic, mitral valve is small, aorta I'm not sure but looks small. So it's a single ventricle, it's hypoplastic, left heart. So how do I decide left, right, and hence it's very important beforehand to just first have a clear understanding about left and right. Sometimes it does happen when we are just sweeping. As soon as we put the probe, we will see a aortic arch. So I usually have a feeling that it's okay to finish off that understanding and then start from fresh, because sometimes the baby will not pose for the aortic arch later on. So at least my arch issue is settled. And after that, but whenever I start, I want to start systematically from right, left. So hypoplastic left heart, we know that, you know, this is one single ventricle lesion where we need multiple palliative surgeries, and the survival is not great. This is practically not our Indian experience, but I would say 50% survival at 5 years of age. And actually, there is a lot of drop off between stage 1 and stage 2 also. Now, the question comes, whenever I have a hypoplastic left heart, what all things are going to be mattering me at birth? So as you see here, the PFO, which is going to be very, very important. Children who have restricted PFO, when they are born, they can have extensive amount of pulmonary venous congestion, and they will not even give you time for any intervention. They're very sick. Their response to novel stage 1 is not that good. So when I see this in fetal life, what all will I have a look? Mitral valve, aortic valve, size of PFO, presence of tricuspid regurgitation. Anything more than mild tricuspid regurgitation may not even be listed for novel stage 1. So presence of tricuspid regurgitation is an indirect understanding how the RV is going to take over time. Hypoplastic arch coarctation, because this is what is going to increase or make the first intervention a little more lengthy and complex. And the RV function. Obviously, I need prostaglandins. Early Norwood stage 1, extensive counseling. The rate of termination has increased significantly for hypoplastic left heart. So the number of surgeries being done are becoming lesser and lesser now. But sometimes we are not fortunate to get this before 20 weeks, and hence this thought process should be there. The hypoplastic left heart is one lesion where there has been seen a positive influence on long-term morbidities and including neurocognitive outcome. So if it gets picked up and we do in a controlled way versus it gets picked up a week later, there's a lot of difference in terms of long-term outcome of the baby. So this is one lesion where there is a positive impact. Now let's see this. I'm just going to play one by one, and all of you can write your answers in the chat box once you have any thought process. Okay, now see, all the pictures are not having actually the left and right on the same side. So let us just go in the first picture. What is it that is so abnormal here? I can give a clue. This is left and this is right. This is left and this is right. So what do you see here? RA dilated. Okay, this is left. See, these are the pulmonary veins. This is the left atrium. This is the left ventricle. What is it here between the LA and the LV? LA dilated, yes. Aortic valve. Okay, so far in this view, we haven't opened up, but that's right. Your diagnosis is right. This is actually the mitral valve. We have still not gone into the outflow tract. So in this view, you can see this. This is the mitral valve. What is happening with the mitral valve? Yeah, it looks like as if it's a calcified mitral valve. Agreed. And there is some mitral regurgitation. See, these are the hepatic veins. This is the RA. This is the RA, RV. This is the left ventricle. This looks like a calcified mitral valve and there's mitral regurgitation. Now let's see here. What is there? Okay, I can give a clue. This is the PFO. So here what is happening is the PFO is actually shunting from left atrium to right atrium. So when will a PFO shunt from left atrium to right atrium? So it's very important always to make sure that you focus on the direction of PFO. This is very important to give you clues to the hemodynamics. Normally the PFO should shunt right to left. If it's shunting from left to right, I know that there is something to do with an abnormality in the left heart. This is a Doppler of my aortic valve. So my aortic valve Doppler velocity is 300 centimeters per second. Okay, HLS is like lesion, a little more modification because I can show you the left ventricle. The left ventricle is normal sized. Yes, HLS is like lesion. Also, the PFO will be shunting left to right. Here, my aortic valve velocity is 300 centimeters per second. Is it normal? Normally, the velocity across aortic valve should be usually around 80 centimeters per second. Yes, so 300 centimeters per second, my velocity across the aortic valve does not look okay. So whenever I have this, normally I'm not going to do Dopplers for every single similar valve, but I will usually see some turbulence here. If my PFO is left to right, I try focusing on the aortic valve. So see, this is the left ventricle, this is the aortic valve, this is the anything very typical here. This is the aortic valve. I have a dilated ascending aorta. Now, when I have dilated ascending aorta, turbulence across the aortic valve, yes, left ventricle shows EMF-like picture. Very good. So it means that my left ventricle, yes, aortic valve cusps are thickened and my ascending aorta is dilated. So I know I have a lesion at the aortic valve. Very likely it could be a bicuspid aortic valve. And I have the left ventricular myocardium and the mitral wall, both of which have some amount of calcium deposition or hyperechogenicity. And the last and the most important thing is shown here. You can see here, this are my outflow tracts. This is my LV outflow tract, which has actually a retrograde flow. So in this situation, when I try to see even aortic arch and ductal arch, normally we know that the flow across both the arches should be in the same direction. If I have flow in a reverse direction, I know one of the valves is not okay. Remember, your hemodynamics are going to be very different in fetal life compared to postnatal life. I will not be able to take number by number here. So these indirect things like flow across the arches not in the same direction, PFO shunting left to right, mitral valve and LV not looking okay, and turbulence across the aortic valve. And last is a discrepancy between the aortic valve annulus size and the ascending aorta. All these will give you a clue about a possibility of aortic stenosis. So now aortic stenosis, all of us know, most common would be bicuspid when I see this in fetal life. And what issues I'm going to get is in terms of LV dysfunction, pulmonary venous congestion, compromised cardiac output, and there are few things which would predict the survival. If my LV is dysfunctional, if I have EMF, and my need for intervention very early in life, which is going to be balloon aortic valvotomy. In general, you would say, if I need an intervention in neonatal period, 70% survival is going to be there, but chances of recurrence are significantly high. So chances of needing re-intervention in terms of surgical or reballooning has to be explained. So when I see something like this in fetal life, what all will I pay attention to? Am I documenting forward flow across the aortic valve, or is it almost atretic? Do I have aortic regurgitation? This could point towards a possibility of a dysplastic aortic valve or a unicuspid aortic valve where the response to balloon is not going to be much. Presence of mitral regurgitation could be a ischemic CODI evidence already there. Presence of endocardial fibroelastosis, LV size and function could also be impacted. Direction of flow into the aortic arch means it is critical aortic stenosis, and association, aortic stenosis, association with coarct is well known, and hydrops. Also remember association with sort of non-cardiac genetic issues like Turner's, etc. So all these will decide if my aortic stenosis is not critical, I may be okay not delivering in a tertiary center. But if I have all these like PFO right to left, aortic arch flow reversal, or LV dysfunction, or EMF, I want to deliver in a center where I can do ballooning, and prognosticating about long-term need for repeat interventions is important. So I think that was it. Now we have the next. Okay. Yeah, somebody's written Shone's complex. It could be a possibility. However, here we had a direct correlation of the mitral valve disease because of the aortic stenosis, but will not be able to rule it out probably if there is an associated supramitral membrane, etc. Then that comes into picture. Yes, that's right. Now we come to the next case. All of you can see this. It's a simple video, just a 4-chamber video. And that's when it's, because I've not shown the situs, I am writing it here. This is left and this is right. Do you see anything abnormal? Yeah, so, you see Epstein's because this chamber, the right atrium, see, this is the right atrium and this is the right ventricle. But you can see here the tricuspid valve attachments are completely normal. So the RA is huge. Maybe RV is dilated, but RA looks a little more bigger than RV, right? But the right heart is dilated. And just to complete the understanding, my rest of the outflow tracts, 3-vessel view and all that was completely normal. So when I have RA so big, somebody saying dextroposition. Okay, I will just tell you here 1 minute. The dextroposition, I'm not going to comment on this because, in fetal life, I may not be showing you an exact well centralized heart. I'm just trying to focus on a particular part of the heart better. So dextroposition may not be a stand to be taken. Dysplastic tricuspid valve and dilated RA, I fully agree. So in this situation, you will focus a lot of the tricuspid valve. Actually, whatever you see, the structure of the tricuspid valve looks okay. It does not look as if the leaflets are thickened. It does not look as if it's displaced or tethered. So practically dilated RA and maybe to some extent RV. I'm not sure. Now, I will tell you something. This is big. Recently, it has become a very common thing about suspected coarctation. If my RV is also equally dilated in the other views, then the question comes, I have unexplained right heart dilatation. If my RA is only dilated, then one classical possibility is going to be right atrial aneurysm. Just as we saw the LV aneurysm, RA aneurysm is a possibility. How will I differentiate it from a disproportionate cardiac chamber situation where my right heart is much more dilated? If I have RA aneurysm, my right atrial dilatation is going to be out of proportion to the dilatation of the RV. That could be one clue. The second differential for isolated RA aneurysm is actually a rare possibility of absence of pericardium in a localized area. Now, these are the DDs, but generally, if I end up having RV also a little bit dilated, then this will fall into the picture where I have ventricular disproportion. Now, normally, the right heart is the one which is dominating in fetal life. To what extent domination is possible? 1.2:1 is the maximum dimension. Minimum is 0.9:1. That means usually RV, LV are equal, but RV can be 1.2 times LV max. After that, I need to think that this is not normal. Now, if it is not normal, what is the cause? So I run through, as all of you thought about tricuspid valve disease. Any tricuspid valve disease, presence of tricuspid regurgitation can cause that. Second is, if I have my foramen oval or ductus arteriosus prematurely closing, especially in third trimester, also my right heart dilatation could be unexplained. But if those things are ruled out, then I will think about a lesion in the left heart. So I go through and run through my left heart structures and check the Z-scores. If the Z-scores are acceptable, LV is reaching apex. Practically, I would think this may not be HLHS, but then it can be a hidden coarct. So this has become a very common thought process with a lot of fetal medicine specialists where I have ventricular disproportion. The possibility of coarctation, as all of you know, cannot be ruled out in pregnancy. So subtle difference here. The evolving coarct possibility always stands with us, especially in second trimester where we have a long way to go. Coarct could actually evolve over time and manifest after birth. So how do I go about it? Remember that this concept about ventricular disproportion, once you have ruled out the other things, has a moderate sensitivity, low specificity, and a low positive predictive value. So this is very important in counseling the parents. What is important is measurements of the ventricles at end diastole before the AV valve closes and the long axis dimensions in mid cavity. These measurements are important and you compare the left and the right. You could also do the Z-scores, but for RV, which is a little more dilated, I think Z-scores help less compared to the measurement of the mid-cavity just before closing of the AV valves. So if it, normally the LV is to RV ratio should be more than 0.6. If it's less than 0.6, the second important thing is isthmus and duct ratio. So isthmus is to duct ratio. If it's less than 0.7, the Z-score of the isthmus value for that gestational age, and if the diameter of the pulmonary artery is much bigger than aorta, these all could point towards a stronger possibility of coarctation. Also try looking for associated anomalies like bicuspid aortic valve, mitral valve, which does not look okay, a presence of a ventricular septal defect, and LSVC. LSVC, in association with coarctation, is well known. And to that extent that fetal medicine specialists would say that if they have an LSVC even without disproportion, they would want to follow up after birth and rule out coarctation. And as all of you know, coarctation, in case it is there, the corrective surgery might be needed in neonatal period with multiple methods which are there. So when I suspect a ventricular disproportion, what all will I take? Very important that you see for RA and RV dilatation, which is almost equal. If it is equal, then you find the Z-scores of isthmus, ductus, and individual left heart structures, and then compare the right and the left heart structures in terms of mid-cavity, isthmus, ductus ratio, see for additional lesions. Sometimes it gets difficult to assure that this is no coarct, and in that situation, it's always better to take all these precautions. Remember, ventricular disproportion is one such situation where you are actually telling the parents neither a confirmed heart disease nor you are ruling it out. So a lot of counseling would help the parents to continue pregnancy. The long-term outcome is going to be much better for a coarct if picked up antenatally. These babies do much better long-term. Now, You can see this next. I see it's already closer to 9:15 to 9:20. We will take one more case if it's okay for all of you, and then maybe decide. If all of you want one more session for structural lesions, we can do it next month. So let's see this. This is descending aorta. So just a clue for all of you. Any thoughts? Yes, yes, very good. So you can see this is left ventricle. See, this is a typical slipper-shaped left ventricle descending aorta. And the left ventricle is giving rise to one vessel which is clearly bifurcating, and the right ventricle to another vessel which is going straight. The second thing is the arteries are not crossing. So this diagnosis is usually not very difficult. One, because arteries are not crossing, and second, because you have a bifurcating vessel coming from the left ventricle. Sometimes this situation is confused with, for example, an AP window or absence of one pulmonary artery. It could get confused with the diagnosis of transposition in fetal life. Now, you saw that the interventricular septum was intact in this child. Less possibility of having non-cardiac malformations. And all of us know that earlier the diagnosis in fetal life, we end up getting an arterial switch operation compared to Senings, and this is what is going to be much better for the child. What are the risk factors is going to be actually presence of VSD. Risk factor in the sense that long-term outcome of children with transposition with VSD after an arterial switch is a shade inferior compared to arterial switch intact IVS, though these kids are much stable at birth. And the weight of the child associated coarctation could change the surgical intervention risk, and coronaries which are abnormal. However, these babies do wonderful. 90% survival for 15 years is a very good future. Chances of deoperation in up to 10% of cases in terms of supravalvular issues of LVOT and RVOT. So for transposition, what all will you see when you see this? One, pay attention when you see a transposition in fetal life. Pulmonary artery smaller than aorta, because this could be a hidden thing for pulmonary stenosis. Remember, pulmonary stenosis is not going to be as evident as postnatal life in antenatal period because the pulmonary circulation is just 10%. It's going to be torrentially more after birth where PS can unmask. Then your management cannot be arterial switch. The child clinically will behave well, and your long-term prognosis is going to be very different compared to arterial switch. So pay attention to the PA size in aorta. Normally, my PA should be as much as aorta at least. Any indirect evidence of coarctation, patency of PDA and PA4. This is important because theoretically there is a possibility that PA4 can become restrictive, and again these children can become sicker very soon after birth, and presence of tricuspid regurgitation. And hence, these issues, we know that prostaglandin, septostomy, and arterial switch operation, long-term prognosis is beautiful with arterial switch operation, and hence delivery in a tertiary center, etc. Those steps need to be considered for a transposition. And diagnosis in fetal life is going to be rewarding for us, very positive very positive documented papers are there where it can make a lot of difference for these children long term. So I think this is related to transposition. Should we end our session today? And maybe, all of you can message Kavita based on your thoughts. If you want to continue the fetal echo series, the pending structural lesions, we could do it next time, or else we can take some other topic. You could just message Kavita. Any questions so far, if anyone has it? Yeah, we can do it. So what we will do is maybe the next month in September, we will continue, because I think it's better that we finish off the fetal echo series together. So we'll do it the next time. You want to do the questions next time also? We can do it all together. Okay, fine.